This is a really difficult topic, but I wanted to talk about it only because I've had a couple of instances where I've shocked an asystolic patient only because of what I've found on echo. And then I saw the field study, which I sort of showed you on the first day. We'll talk about it again under Pearls of Resus. And I wanted to pose the question. I'm not telling you to do it. I'm asking you whether you think we should do it. I'm going to do it, but it's whether you think we should do it. Who saw the movie Flatliners, the original, not the rubbish remake? Yeah, that was a good one. That was a good one. I still have nightmares over that. So, is all asystole the same? And the answer is no, it's not. Asystole secondary to ischemia, where you get all the metabolites and the heart cells dying, is very different to asystole second to a pulmonary embolism or asystole second to drowning or asphyxiation. And the survival rates from those different types of patients are different. So not all asystole is different. So we don't just think about asystole as one thing that occurs and just say they're all dead, because there's different survival rates from different types of asystole. So we've got to be a little bit careful about how we consider that. And that's what prompted this kind of thinking that I had on this. So here's a case in the literature. 43-year-old male from home, unresponsive. He's got an alcohol history. He has been drinking a bit. He's got profuse hematemesis for a couple of days, and he is unconscious. Ambulance are called. The paramedics intubate him on site. He loses output. CPR in progress. He gets some adrenaline in. Gets 3 1 milligram doses of adrenaline. Remember, I stop at that. I don't think adrenaline confers any benefit after that. He's in PEA though on arrival. They give him some more CPR. I think he probably gets some more adrenaline in that, and he also gets some blood because he's had the hematemesis. He progresses from PEA to asystole, which is not uncommon. Everything progresses to asystole basically. So he progresses to asystole, but prior to stopping the resuscitation, they do a quick echo. And he's got fine ventricular fibrillation there. You can see the fibrillation. So motion at all, any sort of twitch or anything of the muscle is important. The valves don't matter because you get movement of the valves as you're giving fluid. But this is a fine ventricular fibrillation. So this guy gets shocked. And that's his post-defibrillation ECG, and he perfuses after this. Now, he's not great protoplasm. He's got alcoholic liver disease, he's got a few other things, get complicated. He doesn't do very well. Okay. And most of them don't do well. But what's important there is that we had an asystolic patient that wasn't asystolic. He got a shock, and he got an organised rhythm again and a perfusing rhythm. The outcome of these patients is poor, but I put to you, would it make a difference if we were doing this earlier rather than later? So should we shock asystole? Because the old thing of you can't kill dead, right? What harm can we do? We spoke about this cracking the chest yesterday and what effect it might have on those around you. This person is dead. You can't kill them anymore. One shock won't matter. And I talk about one shock. The ALS guidelines don't support shocking asystole, okay? But let's just have a look at the advanced life support guidelines. Conspiracy theories abound. Let's have a look at these. So in 1992, the American Heart Association said that delivering shock was going to be dangerous to the heart because it promoted a parasympathetic storm. They went on to cite a couple of papers after that. One was a pediatric paper, and they were talking about adult resuscitation here, so it doesn't really apply. And the second one actually showed that survival was better without a shock, and that's what it's been based on. After this, a few years later, a couple of other papers came out and they were used, and they were total rubbish papers as well. So what's it based on? As we progress, in 2015, the European Resuscitation Council says, look, maybe we shouldn't just forget these patients. Let's look for some P waves. Maybe we can paste them. Maybe we can do something else. However, this do not shock asystole remains. All of the stuff about shocking a heart is dangerous has been removed from all the guidelines, and it was removed over 10 years ago. But the no shock asystole still applies. But we don't necessarily always do what the guidelines or the best evidence says. We've got to think for ourselves and see what's best for our patients. So let's delve a little bit. There's not a lot of evidence. The studies are old, but in this one study of 119 patients, when they shocked them, over 8% of them got a perfusing rhythm. Did they do any better? Not really. When did they shock them? Very late in the piece. There are tons of case reports, and since writing a blog on this a while ago, a few months ago, I've had so many emails of doctors that have said, I shocked a patient, they've got an organised rhythm when they were in asystole. Quite surprising. That's why I thought I'd speak on it. So what do we know? We know that in most adults, arrest is a VF arrest, and it progresses to asystole. Okay? So when you die, it's asystole. We know at best survival has been quoted as up to 2% in asystolic patients. And in flatliners, you know, the movies are never wrong. The movies are always right. And they shock flatline all the time in the movies, and they all come back. So this is where I get most of my learning from. So it must be right. So I'm going to think about this a little bit more. Up to about 8.5% quoted in what we have in the literature shows that these patients that we call asystole are actually in ventricular fibrillation, and we're not picking it up. And for every minute that we delay defibrillation, survival drops 7 to 10%, somewhere in there. We also know, though, that the amplitude of VF determines the response to defibrillation and the prognosis of that patient. The higher the amplitude, supposedly the better chance of defibrillating that patient. And that's really a time-dependent phenomenon. The longer we leave it, the finer the VF becomes until it progresses to asystole. Is it really asystole, and why might we be missing it? Well, there's some technical issues that may be occurring there. The body habitus of the patient, and it could be a low amplitude VF. Low amplitude VF does not mean that it can't be defibrillated back into a perfusing rhythm. It just means that it's harder and it's progressed for longer. I showed you the field study. In the field study, they found that 38% of patients with ECG asystole, ECG strip asystole, had coordinated cardiac motion. They found that 58% I think it was, of patients in PEA on echo had coordinated cardiac motion. Right? So it's not just an electrical impulse, it's coordinated movement of the heart. So we should be thinking about this a little bit more. So I have an approach, and my approach is I don't shock everybody, of course, but I shock potentially a particular group of patients, the ones that I think might be in VF. So my approach is I commence one cycle of CPR. If they come into the ED and they asystole, you know, they've had I don't give them any more. If they've had 3 doses of adrenaline, they're done with me. I give them one good dose of CPR to see if there is VF, if I can increase its amplitude. I then increase, and the guidelines actually talk about increasing the amplitude reading on our monitors before we call it asystole. They actually specify that, so they've realised this. So I increase the reading on the defibrillator to see if I can pick up a fine VF. The next thing I do is during the rhythm check, you want to check more than one lead, because the guidelines in fact also say you should not call it on a single lead. Now, scanning the leads becomes difficult. What you have to do is you have to disable your VFVT alarm on your defibrillator to do it. I don't think it's going to affect us. We know what we're looking for. Okay, so if you disable that, you can scan the leads. And you'll be quite surprised that in some of the work it's been shown that one lead may not show it, but another might. I do a quick echo. Okay, and the echo occurs during that pulse check. Do we do a pulse check? No, we do a rhythm check. And you've got about 6 or 7 seconds. So what we do is we do the echo and we loop it, and we just watch it really while CPR is going on if we need to. And if there's any ventricular fibrillation, and you know, if we believe that we've maximised perfusion, and I think a good course of CPR is fine, I will deliver a shock. Single shock. Don't just keep shocking. A single shock and see what happens in these patients. If you don't have the capacity for echo, if you're in a rural sector, you can make that decision very early in the piece. In an asystolic patient that's not responsive, you know, asystole for more than 9 minutes, 9.5 minutes, the study shows 0 chance of survival. So if you're at that point, There's nothing wrong with giving one good course of CPR, one good cycle of CPR and delivering a shock. And then you stop there if nothing happens. But there's a subgroup of patients that will respond because they are in VF, they're not in true asystole, and we're missing it. So I just want you to think about that as because we're changing. In a few years, I got up and talked about. I talked at one of the ASLM conferences, and I spoke at EM Core about changing the paradigm, having this paradigm shift, in which we start thinking differently about resuscitation. And the ECMO stuff started coming out, and everything else after this. And I think this is the next stage where we really start to use the echo a lot more. We start to think about our individual patients rather than think about guidelines. So I put it to you, accept it, don't accept it, but think about it, because I think it's an interesting concept. Thank you very much.